This is Caleb from the National Rural Health Resource Center with CAHS. Today we have Sarah Young, who will primarily be facilitating our webinar on Flex, PIMS, updates, and report out. We also have John Gale from the Flex monitoring team to present some additional slides and information. Sarah, do you want to get us started?
Thanks, Caleb. As most of you on the webinar know, I am Sarah Young, and I'm the program coordinator for the Flex Grant Program from the Federal Office of Rural Health Policy. This webinar is really for Flex coordinators and some of our other national partners and research stakeholders in the Flex program to help us all improve our understanding of the data that is being collected in PIMS and how we are using that data for the Flex program, and hopefully prompt some new ideas about how we can get more value from the data that we work so hard to collect in the future. So I'm going to review highlights of the timing, history, and purpose of PIMS data collection, and then present some of my initial analysis of what you all as State Flex Program Coordinators reported in PIMS for the FY15 grant period. Of course, that is the reporting that was just done last fall in September and October of 2016. And then we'll briefly discuss future PIMS data collection and ways that we might make the PIMS system work better in the future. That is a complicated discussion and probably not something we'll have a chance to get into a whole lot today, but it is a very important discussion that I look forward to continuing to have with Flex programs, State Flex coordinators, and our research partners. So just to review where we are, hopefully you have all seen this timeline before and be prepared to see it again, because I like to use this to frame, whenever we're talking about events in the Flex program, where are we in that 3-year Flex grant cycle, and how does where we are on the calendar line up with where we are in the grant program. At the moment, the red triangle is on January 2017, which is really right in the middle of the second project year of the 3-year Flex grant. But pay attention to the second line in green. Even though we are in the middle of the project period, we're coming right up to the very last non-competing continuation progress report that will be due for this project period. And it's also important to remember that the non-competing continuation progress reports and the Flex PIMS data reports happen on different cycles. The NCC actually happens in the middle of the next grant year, while the PIMS data is only reported after the end of the grant year that's completed. And so keep in mind that you're all working on at least 2 different reports, 3 if you're also involved in the financial report for the grant. And we want the PIMS data report and the non-competing continuation progress report to actually complement each other, which is a challenge when they happen at different times like this. As background, as you probably know, PIMS stands for the Performance Improvement and Measurement System, and it's an online data collection tool accessed through the HRSA electronic handbooks. The purpose of PIMS is to collect a limited set of Flex grant-specific data using standard questions, and one thing that we changed this year with the FY15 revisions was to give you options for flexible category selection, so the categories you see actually match the categories of work in your state's Flex work plan. If you're involved in other HRSA grant programs, a number of other FRHP grants and grants in other HRSA bureaus also have PIMS data collection systems. So for this conversation, we're talking about Flex PIMS, not anyone else's. And just to remind you what it looks like, that is the splash welcome page for the PIMS system when you are logging in to enter data or review your data. And another thing this splash page tells you, if you ever take the time to read it, is a big reason for this PIMS system is to collect data for the GIPRA reporting that we are required to do. So what is PIMS used for? It is, first and foremost, a data tool to meet our federal reporting requirements for the FLEX program. The FLEX grant actually has 3 performance measures that are part of the HRSA annual performance report. You can read those in the complete HRSA performance report that is available on the HRSA budget page on the HRSA website, which is linked in that blue hyperlink on this slide. But in addition to meeting those federal reporting requirements, I also want PIMS to really be a tool that we can use for program-wide monitoring and evaluation. Hey, somebody's got some background noise. Could you mute your line if you're not asking questions? So to conduct that, a tool that we can use, both myself and my colleagues in the federal office, but also our research partners like John Gale and the rest of the FLEX monitoring team. And also, ideally, this data can inform individual state-level program development. However, I want it to be as useful as possible for all of those purposes, but the federal reporting requirements, of course, have to take priority, which is a challenge. So the topics collected in PIMS since our revision of the system for the FY15 reporting period is really focused on concepts of performance improvement, program spending, and tracking CAHS conversions. I realize, and you all realize, having done this, that PIMS only collects information on a limited set of everything that state FLEX programs do. CAHS performance improvement is one of the core features of your work, but it's certainly not the only thing you do. And this is why the NCC progress reports, your grant narratives, whoops, we're losing slides. If they come back, I'll keep talking. You can remember what was on the screen. And other individualized program-specific outcome measures are also very important parts of how you show progress in your state FLEX grant. And I also want to keep in mind that CAHS performance improvement and FLEX program spending by category really are 2 different things. And a comment that I've heard from some of you and really take seriously is that PIMS, as it's currently structured, does not reflect everything that we do in FLEX. I completely agree. And if you have suggestions for additional data that we should collect in PIMS to better reflect the work of your state FLEX programs and of your fellow FLEX programs, please do let me know. The more specific you can be about what information we should be collecting, the better. This, like any performance improvement project, this is an ongoing improvement effort. So with that, I'm going to go pretty quickly through some of the data highlights that I've pulled out of the initial PIMS data. And this slide is pretty busy, but I was trying to sort of summarize the trends that I saw in the big buckets of where you're reporting spending and flex program investment. My biggest takeaway on this slide is that we clearly need to have clearer and more specific guidance on how to report the spending categories, because there is a lot of variation state to state in how much of your spending was non-specific and not reported in a individual flex grant category. Zooming in a little bit, here is the distribution of national flex spending by the 5 current core areas of flex grant. No surprise, the largest flex investments were in financial improvement and quality improvement, because those are core areas of work for state flex programs. It's interesting to note the quite small amount of spending going to CAHS conversion these days, which reflects to me the fact that CAHS conversion is not a major focus for flex anymore, given that most states don't have any hospitals that are potentially eligible for conversion. Zooming in even further on spending and investment levels and quality improvement, I can ask the question, where is quality improvement spending focused? As you would expect, a lot of it is focused on the required activities in 1.01 through 1.04. It's interesting that there's also a lot of investment going on in patient safety. So those are some of the healthcare required infection measures like CAHS and CLABSI and other patient safety activities. And of course, you're investing significant resources in doing quality measure reporting, because that continues to be a challenge for many CAHS. In the financial improvement core area, there's really projects to improve finances and operations. Investment is spread across the 4 different major activity categories. And similar in population health and EMS, although somewhat less is invested in improving EMS capacity and operations than some of the other core areas around population health and statewide needs assessment activity areas. And then finally, just to hit everything, a dozen or so states are investing, sometimes quite a bit, in developing innovative model efforts. So that was a really quick survey of some of the spending levels. Now I want to shift our focus to the measures, which are really focused on those CAHS performance improvement questions. We'll start with a couple of measures that we have proposed to HRSA as new performance measures for the FLEX program. And then I will show some of the other data that may evolve into program performance measures in the future, although it's not there quite yet. So anyway, the part A of the proposed FLEX quality improvement performance measure is this report of the number of CAHS participating and the number showing improvement in core quality improvement domains. It is a new performance measure, and we're really trying to show the way that FLEX works on quality improvement. I think one thing to really keep in mind about this number, as it's presented here on the screen, it's 2 numbers and a percentage. This is not the kind of number that, like some programs that have measures of clients served, that you expect to increase every year. We're really for the FLEX program, we're really focused on quality above quantity, and I don't have any idea of where this number should trend. I think it's important to monitor where we are, though. And we're really emphasizing the ways FLEX programs are engaged in quality improvement activities. In parallel to the core quality improvement proposed measure, we also have an optional quality domain proposed measure. As you would expect, there are many fewer CAHS participating in some of the performance improvement activities in the optional categories of the grant because some of your state programs aren't working in those areas of the grant. In parallel to the quality improvement CAH level reports, we can also ask the question, how many CAHs were participating in financial or operational performance improvement projects, and of the ones participating in those projects which showed improvement. So this is just one data point out of that core area 2 set of questions, looking at the numbers of CAHs reporting participating and improving in revenue cycle related projects. Just to summarize what was reported in PIMS this year, here are the numbers, again, for those questions that ask you to select which CAHs were participating and which CAHs were improving in your state. Here are the numbers for the activity categories in the population health and EMS core area. And for CAH conversion, again, this was a relatively small number of events. Only 20 hospitals requested and received assistance from state FLEX programs in exploring conversion, and 9 hospitals converted to CAH status during the 2015 budget period. Compared to the over 1,300 CAHs that we serve, that's a pretty small number. And then finally, for the Innovative Models of Care core area, you reported a total of 135 CAHs across the states with innovative models activities that were participating in innovative model projects. So that was a speed survey of some of the data that was reported in PIMS this year and some of the ways that I am starting to look at it. Also, I want to emphasize that we are pulling FLEX program data from other places, and a good example, of course, is the MBQIP reports. We could have, but didn't, ask states to report in PIMS the number of your hospitals reporting quality measures. The reason we didn't ask that in PIMS is because we already had that information through the MBQIP reports directly, and we don't want to cause double burden for you to report data that we already have from another source. So, but just to give you an idea of what that data looks like, here is a summary of the CAH reporting rate for the currently available data in the different MBQIP measure categories. And I don't have each measure broken out individually. The outpatient measures are divided into measure sets. So there's the blue bars are the emergency department transfer communication measure. The orange bars are the AMI measures that are part of outpatient heart attack and chest pain measures that are part of the outpatient measure set. The gray bars are the emergency department throughput measures that are part of the outpatient measure set. And the yellow bars are the pain control measure in the outpatient measure set. The blue line is HCAHPS, and I know that's a 4-quarter rolling average, so that's just as of the quarter ending for the report. for the purpose of this display. And then the green line is the IMN2 reporting rates, that single inpatient measure. And OP22, patients left without being seen, and OP27, healthcare facility personnel influenza vaccination rates are only reported once a year. So they're just single dots, single diamonds on this graph. Anyway, with all that, what I'm trying to look at here is to put our quality reporting rates together on one slide so we can look for some of those trends over time. One thing that I really want to call out, because it reflects a lot of effort by flex coordinators and by the CAHS in your state, is how much we have increased EDTC reporting rates over just the past year. That is really exciting. The same thing for the ED throughput reporting rates. That one really stands out as increasing reporting rates in the past year. So with that quick data survey, some of the next steps and questions that I'm looking at with Caleb, I'm working with Caleb and John Gale and a group of flex coordinators to develop a data tracking tool for PIMS to make it easier for flex coordinators to collect the information that you will need at the end of the year to report about that individual call level participation and performance improvement in PIMS. Also working to listen to all your questions and comments and improve the PIMS instructions and definitions for next year's reporting cycle. And I'm working with the IT folks on improving the interface. We're not going to make big changes to what the questions are in PIMS, but I think there are ways to improve that reporting interface so it's easier for you to use. One good example, for instance, has been to have a select all toggle. So the activities where you have lots of CAHS participating, you can select all and then uncheck the 2 or 3 that aren't, instead of having to check them all one at a time. So some questions I have for you, and we'll maybe take 1 or 2 minutes if we have some quick questions, and we can ask more at the end of these presentations, assuming we have time. Are there other measures that should be added to PIMS that aren't there now so that the data in PIMS really does more completely reflect your flex work? And are there measures that should be removed from PIMS because they're in there but they don't really reflect your work? I'm interested in comments about both of those issues, and again, you can ask them on the line now, but you can also contact me after the webinar once you had a chance to think about it. That's just fine. So, as you know, *2, if you want to unmute your line. Are there any questions, either about my questions or about other things in my slides that are burning in someone's mind right now? *2.
This is Kenny.
Hi, Kenny.
You know, I know you indicated at one time, and I don't remember if it was at the Flex conference or just in our conversation we had one-on-one, that we would, you know, the next round of PIMS, in addition to what we report on for FY16, we would actually even go back to report any additional information on FY15. So, you know, so I guess that's my question is, you know, at the time we did the FY15 PIMS, we probably could not tell if any improvement had been done on a lot of cases. You've probably seen that, but, you know, by the end of this next project period, we probably would be able to. So, you know, I'm kind of curious how that would look and how we would be going back and reporting that again.
Yeah, you're right, Kenny. That is a question that I've gotten before and have been able to initially think about, because I think, in general, you know at the end of the year which cause you worked with, on which ones participated in performance improvement projects, but you don't necessarily know the results of those projects because a lot of performance improvement work takes time to play out. So what I have envisioned so far, and if you're interested in being one of my guinea pigs, I maybe can get your help on that in the next few months, is to basically have next year's interface give you the option of reporting. Again, you'll have a list to select participation for FY16, but then to give you the option of reporting improvement that could relate to either FY15 or FY16, and then the screen would also show your FY15 participation report. Because I agree with you that it's entirely possible and even likely in the case of many types of projects that you won't see improvement for many months or a year down the line.
Yeah, I'd be more than willing to be a guinea pig, so feel free to contact me or whatever. So.
Great. I'll keep it in mind. Thank you. Any other questions on the line? Press *2. Hearing none right now, let's move on to the rest of the slides, but please do, I think you all have my contact information, but just in case you don't, there it is again, and please do plan to contact me when you have more questions come up. Okay, Caleb.
Thank you. So as Sarah mentioned, one of the things that we want to do is make the PIMS and PIMSing experiences as painless as we can for Flex coordinators. And one of the ways TASC is wanting to help in that is the PIMS evaluation or satisfaction survey evaluation that we sent out a little bit. It's a Technical Assistance and Services Center Task Needs Assessment. So we wanted to hear from you guys shortly after PIMS was completed what your thoughts were, how this round of PIMS was improved, or how it was for you. And I want to share just some of the highlights of that to let you guys know that it doesn't just go into a black hole when we send out one of these evaluations, that we do really take your suggestions and your feedback seriously. And as Sarah said, working with ORHP and the Flex monitoring team on the data reporting tool is one of the things that was identified during this assessment, and that came through at 87.5%, so I'll round that to 88% of respondents felt that a data collection tool would be helpful. So that, coupled with bringing together some Flex coordinators and the Flex monitoring team, that's what we're trying to do right now, is make sure we have a tool that you guys can use and benefit from. We, as Sarah said, don't want anything that we create or ORHP creates or gets sent out into the world to be duplicative or to be additionally burdensome for data reporting purposes or just for your time. So that's something that we're very cognizant of, very aware of, and want to make sure is helpful and not hurting your efforts. A couple of the other things that we asked during the assessment or evaluation were if you could change one thing, or what would make PIMS better if you could change something about it. And we heard a multitude of different things, as Sarah mentioned a few of them. The definitions is something that we heard loud and clear, as far as what does participation mean, what does improvement mean, what what am I really saying when I check this box that this hospital participated and did or didn't, as Kenny said, didn't have an improvement in this area. The check all feature was something mentioned during the assessment, and as Sarah said, that's already being addressed. Consistency among the measures over years, and that's something that, again, has already been spoken to, in that we, as TASC and ORHP and a Flex monitoring team, the technical assistance providers for you guys, really want this to be beneficial for you as much as it is, as Sarah said, a requirement for ORHP to do. So consistency among the measures from year to year will allow everyone to be able to measure those changes over time. And I believe John will speak to this a little bit when in just a second, when he talks about PIMS overall and the identified challenges and issues and some of the review of PIMS. Another thing that we identified, or that you guys identified that we saw on the assessment, was benchmarking compared to other states would be very helpful. And that, I think, speaks to a report out of what was found during the PIMS after the PIMS reporting was completed, and hence the webinar that we're on right now. That was heard loud and clear, and we want to make sure, again, or HP wants to make sure that data doesn't go into a black hole, that you guys, we're all in the boat together, that we all know kind of what's going on and where do I fall in this big mix with everyone else. So those are some of the highlights that were identified during that assessment. So if you did take the time to complete that, thank you very much. If you didn't have an opportunity, please let me know. If you send me an email, if you have thoughts or opinions that you were not able to express on the survey, and we will absolutely take those into consideration. I think with that, Mr. Gale, you are up.
Thank you, Caleb. I will move through these. Good afternoon, everyone. I will move through some of my early slides fairly quickly so that we can move to a discussion of where we are in terms of our evaluation of the PIMS program. And am I doing something to advance my slides? Caleb, can you tell me what I need to do?
On the bottom left corner, there should be a couple left-right arrows. If that doesn't work,
there we are. Yes.
Then I can do it for you.
Thank you. Thank you.
Mm-hmm.
So what I'll do today is very quickly review our PIMS evaluation project that we're doing this year for as part of our FMT portfolio of work. I won't spend a lot of time on reviewing the PIMS measures, although my slides are there. I'll talk a little bit about the challenge and then think about how we can begin to use PIMS for performance improvement. And I think at the end of the day, it's really very important that PIMS has multiple uses. It is used by the Office of Rural Health Policy to document program outcome for Flex as a whole, but it can also be used for internal performance improvement, and that's what we'd like to focus on. So, as you've heard, we're working very closely with Sarah and others at FORHP and Caleb and TASC. So our focus for the evaluating PIMS is to develop strategies to utilize measures to better summarize the performance of Flex programs across the states. You know, there's a lot of activity. I think in many ways PIMS can be used, but I think part of that process will be connecting PIMS to the actual outcome measures and impact measures that you're selecting as part of your program activities. We hope to improve state reporting on the critical measures. There are some issues in reporting that I think will take some work to overcome, and that's not that anyone's doing a bad job, but it's it's a need to fully hone in on clear definitions and have everyone improving the same way. Work on this process, as I say, to use PIMS for internal data reporting, and then provide input into the revision to PIMS for the next funding cycle. So I will move past these since you all know them anyway. So as we've begun to look at the data, and we've begun to analyze the data, we have some sort of preliminary data quality issues that we recognize and that I think are important to work on as we move forward. So I think it's important to review the data reporting instructions and the data definitions. It's not always clear that everyone is reporting the same way. We also have to worry about the denominators. So what denominators are we? It depends on the measure. So if we're looking at overall participation, the denominator would be all the CAHs in your state. But if you're looking at performance improvement, then the denominator would shift to those hospitals participating in a given activity. So it's really important to be clear about that so that you're measuring it accurately. Find some and work on a common understanding of the definitions. What does participation mean? There's a lot of activity in the FLEX programs, everything from meetings, sort of periodic meetings like state CAH meetings, or periodic seminars for the hospitals. But is that participation specifically for purposes of performance improvement? So we really need to work on finalizing a standard agreement that allows the states to really capture what they're doing and not penalize them, but also make sure that we can compare state to state. The same is true for participation and improvement. Helping to report measures consistently over time. I think establishing tracking and reporting systems for each state. I know we're working on a tool, as you've heard. Others have their own tools, and it's my understanding that they are free to use that as long as there's some process. I mean, I think the challenge is understanding what it is we're trying to track and report, and how do you, as state FLEX coordinators, collect that information from your hospitals. And then finally have as Sarah mentioned earlier, have a clear process on how to allocate funds to program areas. There are multiple ways of doing that. There can be direct costs. There can be a process of allocating your non-direct costs across the programs based on activity. Again, I don't know that I want to make a specific suggestion at this point, but I do think we've observed the same variations in reporting based on total dollars. So these are some of the things that we'll be working on with Caleb and Sarah as we work through our evaluation. So in thinking about using PIMS for internal performance improvement, basic 101, it's a continuous systematic process for improving operations. As we look at PIMS, it has the potential to allow for benchmarking across state FLEX programs and to track progress. We do think that it is worth exploring the potential for creating peer groups. Not all of you are alike in terms of the number of hospitals, in terms of the size of your staff, overall budgets, other resources that you can engage and leverage with FLEX funding, and that all makes a difference. So we'll be looking at and thinking about some of those issues. We'll also look to create a comparison of state performance that's meaningful. And we believe this can be done with PIMS when the data is collected and reported consistently. And using PIMS, the PIMS findings and part of the reporting process to enhance cross-state learning and improve buy-in for PIMS reporting. Looking at, so apparently I duplicated them. We move past that. So here's a quick look, and you've all seen some variant of this graphic, that it's a continuous performance improvement process. They create PIMS, feedback, identify feedback forms for grantees and present findings, stimulate grantee performance and improvement, enhance completeness and consistency of reporting, and analyze the data by peer groups. So this process, it is an ongoing process of looking at how you're performing, what is going on within a given intervention that may or may not be successful, and then how to change that, and so that in subsequent years of your cycle you can improve the outcomes. So some of the basic elements that I think are important, we'll go over them very quickly, is establish an ongoing data collection process. I know some states are doing this, but I think it's important to create that process and understand what it is you're trying to measure. So I think as each state creates its own stamp and creates its own unique intervention, there'll be some similarities, but to reflect their needs. How are you going to measure that? So if it's the financial and performance improvement, what are the measures that you want to come up with? Or its quality, how are you going to get that? Are the hospitals going to provide information? We know that at least in the interim and short-term process that it takes some time to get the data through the cost reports and through MBQIP. So is there any sort of day-to-day monitoring, real-time monitoring that you can be doing? What are your baselines? How do you know what is performance? Is 50%, excuse me, is it 50% or 75% performance on a given measure going to be your baseline? It really depends on where your hospitals are, and within state to state, you may have different groupings of hospitals that are struggling more than others. So understanding and establishing those baselines become very important. Setting your progress and goals, both interim and overall. Making the changes, measuring the changes, and following up. So one of the things that we have observed over time with a lot of the outcome and the establishment and the baselines and performance measurement that goes on within the FLEX program is there's still challenges in creating and identifying appropriate outcome measures to reflect what you're doing. There is a great tendency to look at higher level measures that may take some time. And the challenge, I think, for the individual states is to identify what are the steps that lead you to believe you're going to be improving overall financial performance. So if it's improving days in AR, improving the charge master, but really thinking about breaking the projects down into steps and setting those goals and outcome measures in a way that leads you and that you can generally draw conclusions from your performance. We're also working on, as you know, a summary tool. This is going to be very preliminary. It's something we've been working on, but as we pull together and analyze the PIMS data, how do we present it back to all of you in a way that is useful and can achieve the goals that we're all setting out for PIMS? So it's really a focus on a benchmarking, tracking performance over time. So as we work through the analysis and developing the summary tools, we have a structure to this. Excuse me. Analyzing the PIMS variables that are most relevant for peer groups, identifying the peer groups, and we will want to get some feedback from all of you, analyzing the data between the baseline and the first reporting periods to see whether or not we're, how accurate was the baseline. I'm sorry, there. include comparisons and create program reports for the comparison. So my next slide will give you, and this may be hard to see, but it's a sample that we've started to work on that looks at the measures on the left side, and at least in subsequent years we'll be able to compare performance from year to year, so from 2016 to 2017. The number of hospitals participating, the percentage by state, those showing in participation, states reporting, and improvements in quality and performance, I should say. So, and then over time, we'll be able to create a distribution of the states where they fall in terms of their performance improvement. So, I'd encourage you to look at this. I know it may be a bit hard to read, but this is one of the tools we're thinking about. We would also then do some similar tables looking at flex spending. What are you spending for quality improvement, and how is the distribution of your overall flex funding being used? So in terms of using the data, I think there are a couple of things we want to look at. How is your state performing over time? How are you doing compared with last year? And what are the goals based on current performance and the performance over time? What are the goals that you want to set for a subsequent year? So, and part of this is also thinking about what hospitals you're working with. Some of you have many more hospitals than some other states. The New England states tend to have smaller numbers. But are you targeting those hospitals that are struggling the most? Or are you targeting hospitals that are willing to engage and really be part of the process? There are two different ways to go about this, but thinking about who the target hospitals are and then setting those goals appropriately. And looking at benchmarks, are you in line with peers? So some say, for example, financial performance may really be something that is a little bit harder based on the unique composition of spending patterns and reimbursement patterns, state policies around Medicaid, and the number of hospitals you have in the competitive market. But again, whenever possible, thinking about what those peers are and how we define those peer groups will be important. Also, some work using the data to educate and engage your staff. How are they involved in this? What is their role? Are they champions? How much of that gets shared with the staff on a regular basis? I do think that people respond to data and knowing where they are and how well can that be done. What's realistic? States with a large number of hospitals may not be able to serve every hospital in a given year, but setting reasonable targets becomes very important. Defining what specific areas can you improve? Do you, and this is a balancing act, do you want to work with fewer hospitals on multiple areas of activity, or are you working with many hospitals on one specific program area? Is there enough consistency across your CAHs to be able to do that? The data can help you make those decisions. And how do you share the data with stakeholders, policymakers, and funders to document and describe your program impact? And in a nutshell, I think this is where we're going. I'll open it up for questions, but I think I skipped over one slide. I'll just do it off by memory. We have multiple pieces of this evaluation. We are working closely, as we mentioned, with Sarah and Caleb, and having multiple meetings on the different pieces of this component as we start, and then we'll moving this winter and into the spring on the analysis and summary of the data. And we're working on grading these tools to roll up in a way that can be presented to all of you. And then finally, as we start getting these pieces in place, we will conduct some small number of focus groups with some state flex programs to get their input into both benchmarking and peer review process and some of the tools that we're developing. So we do want to hear from you. We are open to suggestions. And I think it's just a collaborative project to make this process as useful as it can be to all of us. That being said, I'll open the floor up for some questions, if anyone has any.
And remember to press *2 to unmute your line if you'd like to ask a question.
John, you've got some questions on the chat box.
I am looking at that. So John's question is, will the improvement metric apply to the 3 levels of outcome, learning, behavioral changes, and long-term changes? It's a good question, and I think it depends on where your hospitals are. In some cases, if you have hospitals that are struggling around financial performance improvement or quality, improvement will be measured by the change in learning, and it'll be a difficult challenge to figure out how you capture that. But in my way of thinking, improvement really has to focus on where the hospitals are. So if you have a group that are struggling, that might be in learning and beginning to see behavioral changes, if you have a higher set of performing hospitals, then it's more appropriate to look at the long-term changes. And then Kathleen, I think I agree with you that it is difficult to look from year to year, but since the PIMS measures have changed for the current grant cycle, I think we're starting that process. I do think over time, as the measures, to the extent that we can keep some measures consistent across the years, then it will facilitate improving and looking at measures over time. But I do agree, it's year to year it can be difficult. You want to look at the body of time and the work that's being done. The other piece of this mix, I think it's worth thinking about as we look at, and I think about performance improvement, and we've had these discussions within our team, is trying to understand what the right time frame will be for performance improvement, and I think it will depend on the project. I think at times it's useful to, it depends on what you're doing. You know, I look at something like the quality metric regarding staff immunization rates. What's the right time for that? Is that a 3-year cycle? Is it a 1-year cycle? I think it's worth thinking about, because I don't know that we have often been very clear about our expectations for improvements from project to project. So that is also, I think, something worth giving some consideration to.
What other questions do we have for Sarah, for me with the assessment, or for John?
While hearing no voices, this is Sarah. I will say, reacting to Kathleen's question about multi-year improvement projects in the chat box, I'd also say that your NCC progress reports are a chance to emphasize outcomes like that, and that will, for one, it will help us in FORHP and John Gale and his colleagues on the Flex monitoring team to get better ideas about what we should be looking at to evaluate the outcomes and impacts of your Flex activities over time, and it's really a chance for you to boast a bit about some projects that have gone really well for you. As I said, I really see your progress reports and narratives and your PIMS data as two complementary views of what you are doing in your Flex programs. They are different formats for conveying information, so you're going to be able to convey different things in those different formats. But we look at all of those, and it's important to have both of those products to help us get the full picture of what you are doing in the individual state Flex programs and the great outcomes you've achieved.
Sarah, I do think that Kathleen's question ties into mine previously as well, that as long as we can, when we're describing improvement by participating hospitals, if we can show various stages of improvement, so so maybe in a year one, you're assessing and training, so you can say, well, they've improved in the knowledge that they've gained. In year two, if they're implementing what they learned, so you can show improvement via behavior changes or implementation of policies and procedures. And then finally, in year three, one could look at the improvement of the outcomes tied to the specific issues worked on. So in that way, PIMS could reflect, I'm just making this up, 30 hospitals worked with every year 1, 2, and 3, but showing improvement, if they have it, in each of those different stages of progress.
I agree, John, in Wisconsin. And that's why we're trying to walk this narrow tightrope with PIMS about getting specific enough about the data that we can roll it up nationally in a meaningful way, but also having structuring it in a way that it can reflect what is individually going on in different states where you're working with different hospitals with different levels of capacity and different needs. Because I completely agree that the goal of a performance improvement project could be anything from improving awareness of infection control processes in our nursing staff to reducing the number of reportable infections we reported to CDC and NHSN next year, and anything in between, because performance improvement is really about starting where you are and getting better. It's not necessarily about climbing Mount Everest on your first try, which is why we don't specify what the CAH performance improvement projects in the various PIMS categories are. We expect you to have performance improvement projects within your state Flex program, but to define improvement in the context of those individual projects that are tailored for where your CAHs are.
And Sarah, I think another example of that might be efforts to improve collection and billing processes by the hospitals. You may have different levels, so at some point improving the turnaround time for billing, so the time in which they get their bills out the door. Certainly smaller, a shorter time period is better than longer, but that may be a beginning step. And the second step is looking at the coding and accuracy of the coding. If they start sending the bills out the door, but they're not taking the time to make sure the coding is accurate, you're not going to help yourself. That might be a different level. The third is then, if you're getting the bills out the door faster, you're improving the accuracy of coding. You can start measuring that with reductions in the number of rejected claims or claims that aren't being paid properly. And then finally, hopefully looking at least improvements in cash flow. So there are ways of sort of breaking these activities down into the component parts and meeting each hospital where they might be.
Exactly. Good example.
Well, I think I might let that be our last comment, as we're just over our time for the webinar's completion. Again, thank you everyone for participating. Thank you, Sarah and John, for speaking on the webinar, as well as everyone who was able to complete the assessment. Again, if you did not have the opportunity to make your comments or thoughts regarding the PIMS data submission, please don't hesitate to reach out to me directly or Sarah or anyone at TASC to get that completed. And if you have any other questions or comments regarding any of the information